I'm okay, sir. I can do it myself. Assalamualaikum, everybody. My name is Dr. Anam. I'm a year 2 resident neurosurgery at AKUH. And the first case is going to be presented by me. So, sir, should I start presenting?
Yes, please. Go ahead.
Okay. All right. So, this case that we're going to discuss, this is a 40 years old female. Current KPS is 70. She had initially developed generalized tonic-clonic seizures back in 2022, at which time she underwent investigations, including an MRI obtained with contrast, which was done on 25th of May 2022, which showed a non-enhancing right frontal lesion. For this lesion, they seek different opinions, including a neurosurgical opinion. However, they were referred for gamma knife radiation without any histopathological evidence of the lesion or without any surgery. The patient then underwent gamma knife radiation in June 2022. The details, however, were not available at the time of when we were compiling this information, so we do not know the exact amount of radiation she had received. But this was done back in June 2022. Follow-up MRI was done in October 2022, which showed stable disease, but the patient had the slowly progression in her symptoms. She developed headache, left-sided upper extremity focal seizures, left hemiparesis earlier this year. Follow-up scan again was done on 18th of June 2023. This time this also included a perfusion scan, and this was done at AKUH, which showed increase in the enhancement of this previously non-enhancing lesion with surrounding edema, as well as the perfusion scans was more suggestive of this to be a progression of the neoplastic illness rather than radiation necrosis. The patient was advised surgery. She underwent new navigation by the right frontal craniotomy and maximum safe resection of this lesion on 21st of June 2023. Post-operative MRI was suggested to be gross total resection. Histopathology, however, was reported later on that this was most likely radiation-induced changes only. And when this case was discussed in our institutional tumor board, it was recommended that the patient is followed serially with the earliest MRI scan, which, however, is pending because this was to be done at an interval of 3 months. So these are the initial most MRI images that were done last year in May 2022, where we can see the T2 weighted digital images, and we can see the hyperintense signals, which are primarily involving the right frontal lobe.
Okay, so Dr. Shayan and Dr. Shumaila, if you want me to stop at any image, just let me know so that if you want to give your comment or you want to add something.
Okay, so over here, these are the T1 weighted images, but the pre-contrast images. The next slide, you can see the post-contrast images. Yes, so we can see that the lesion was essentially non-enhancing. Again, the flare signals. So on the basis of this scan, this patient had received gamma knife radiation.
Just a comment, Jason. It would be nice that if we do these chronologically without knowing the actual outcome, this gives us idea to infer what we think about the images and discuss, because now we already know the outcome, so all of a sudden it becomes irrelevant, right?
Okay. Okay, sir. So we'll do that. So we will not disclose the outcome in the first slide, so we'll keep it for the end, or if it's, if we have not done it, so that will be an open question.
Chronologically, as things happen, so that we can all make our inference and move forward.
Okay. Yeah, that makes sense. Okay.
So these were the pre-gamma knife images, and we can only see that they were hyperintense signals, which were visible on T2 and fair sequences only, and no enhancement was seen at this point in time. And at this point, the patient was advised to proceed with the gamma knife radiation. So the next scan at the time that will be post-gamma knife, and this was done in October 2022, a few months after gamma knife radiation. Even in these sequences, we can see that the flare signals and the T2 weighted signals are pretty much stable, and there was not much enhancement which has developed at this point in time also. So yes, so T1 post-contrast images, we can see that the changes in all the sequences are pretty much stable at this point. If you go to the next slide, that will be having the flare sequences. Yes. So this was in October 2022. Earlier this year, the patient started to deteriorate clinically in terms of her functional status, in terms she started having focal, upper extremity focal seizures on the left side and headache. And then she was being serially followed through MRI scans. This scan was done in June 2023. We can see that the T2 hyperintense signals have significantly increased now. They're also causing mass effect on the contralateral side.
Okay. Dr. Shumaya, do you have a comment on the images that we showed before or this one?
Thank you. Actually, if we compare the images which we saw pre-gamma knife and these images, the first thing which is very strikingly noticed by, I'm sure, everybody, that the vasogenic edema has increased a lot. But if you focus on the previous images, if you just go back 1 to 2 slides, it was more, especially the axial images, it was more centered on the anterior frontal part. And now the enhancement is relatively a little bit posterior in the current images, in which there are post radiotherapy changes. And initially the edema was involving the gray matter and the white matter, like it was a swollen gyrus kind of an appearance. But in the later images, which are post radiotherapy, the edema is more of a vasogenic kind, in which we can see the spared overlying gray matter. So when I initially, since I knew the outcome, so obviously when you know the outcome, you just get biased. But being working in CyberKnife for quite a long period, I'm in CyberKnife like since past 10 years, we are looking at post radiotherapy changes. So it was more kind of a post radiotherapy change to me. I cannot scientifically maybe explain it. It is more of a subjective feeling. By looking at so many scans, I could, make it more. But when I looked at the initial behavior of the lesion, the later behavior was different. So initially it was in the form of a swollen gyrus. There was no enhancement. It was more in the frontal region. It was centered on 1 to 2 gyri. But later on, the changes were more in the region of radiation field instead of the primary lesion. So that was my, findings when I read the images.
Okay, thank you. Dr.
Would
Shayan? Yes, yes, sir.
Sorry, yeah, go ahead, Shayan. My question is just, would a spec have helped and made our diagnosis upfront before surgery?
Can we just look at the perfusion images first, and then we can, carry on the discussion?
So, but in this one, sorry, it's a Anam, do you want to add like the contrast enhancement pattern or something?
Yes, sure. So we can see that the lesion has now developed significant enhancement, which is heterogeneous in nature, as well as we can see that there are 2 satellite nodules which are adjacent to the peripheral margin of this enhancement. So these were the new changes that the patient had developed on these scans. Yes, the ones that you're pointing towards. And again, on the clear images, we can see that there's significant edema surrounding the lesion.
Dr. Shayan, you.
All right. So on these relative cerebral blood perfusion images, we can see volume images. We can see that there is an area of increased flow in the same region as we saw earlier in the on the top right, on the top left, you can see that there is a circumference rounded area which is showing a slight increased flow, and there's also a few other satellite nodules which are dot-like areas which are also showing hyperperfusion in this area on the background of hypoperfused parenchyma. So if we correlate and we co-register with the conventional post-contrast sequences, then we can see that these areas are showing relative increased cerebral blood volume. So based on these findings, but again, the perfusion imaging can also give you false positive results with regards to true progression, and we cannot really say whether this is a true progression or radiation necrosis, and both of the conditions can coexist as well. So for that reason, we ask for histopathology. And I'm not sure if Anam, you missed out a scan in between. There was a scan in March in which the lesion was quite small, and definitely it is in the radiation field, but again, it showed rapid progression in size, and there was also multiplicity, and the edema was now progressing across the midline through corpus callosum. So all these findings pointed out towards true progression. Of course, with some underlying areas of radiation necrosis, but we were not sure.
Okay.
So this is how we reported.
Okay, thank you. So, Dr. Adnan, now you can ask the question. I think you wanted to ask to the neuroradiologist, right?
That's right. I just wanted to ask if a spec would have helped further before proceeding to.
Okay. So then
Actually,
the biopsy
there
was
is
done,
an
right?
there is
Yeah.
an overlapping role of MR spectroperfusion and PET. They all at times they can help, at times they cannot, but we cannot rely on only one thing. We just keep on trying one modality and the other to be more certain.
So these are the post-op scans. Anam, you can continue with, then we can.
Yes, sir. So again, so we have the post-operative images here. At the top, we have T1 weighted atrial images, and at the bottom, we have post-contrast images, where we can see that there's no residue and it was cross-total resection. We can only see the post-surgical changes over here.
These are the post-op. So thank you, Anam. Thank you so much. I would like to ask Dr. Mazhar and Dr. Adnan, for example, if you get this patient with the scans like you were seeing before the surgery, like this scan, what will be your recommendation if it comes to your practice? You would ask for biopsy, you would ask for first your radiologist. What's the protocol at your institute and what we can learn from?
Thank you very much. I think because this patient had a gamma knife treatment and on the follow-ups, it looked like there was something growing up. Perfusion scan was done, but it was non-conclusive type. They couldn't make a clear-cut diagnosis. So if a case like this comes to me, I would definitely like input of a neurosurgeon, because I think there was no histology from the very beginning as well. I didn't, when gamma knife was done, we don't know what the histology was. So it's it's good that patient is fine and the tumor is gone and there is only radiation necrosis, but normally we wouldn't do a gamma knife or cyber knife or but we have to have a biopsy, which is very important. But in a case when it comes back like this, definitely we would like to have an input of a neurosurgeon to either do a biopsy or if it's resectable, to resect it, and that would be my recommendation. And I think they have done it and followed the right way, I suppose.
Okay, sir. Dr. Adnan?
Tissue is the issue for us. For medical oncology, we always say that we need tissue before we can go ahead for definitive treatment. Of course, there's role of radiation in diffuse gliomas in areas where you cannot biopsy, but this was certainly not the case. So that is one of the learning aspects from this case. Something that we see very frequently and we have talked about, and I think this is something that for us is an Achilles heel.
Thank you, sir. We have Dr. Asim Hafiz also with us. He's a radiation oncologist. We can have Dr. Asim's opinion as well, sir.
So I have agree with Dr. Adnan's because biopsy is a essential component of management plan. So in order to embark on any treatment, we should have actually this biopsy before proceeding with the treatment. Because regarding the management of glioma, when you're talking about particular about the glioma, particularly whether it is a low grade or high grade, because as far as radiation is concerned, our treatment field actually depends upon the pathological finding. So if it is low grade glioma, then definitely the margin would be different. And if it is a high grade glioma, the margin would be somewhat different. So currently, when we are talking about particularly about the glioma patient, whether it is a low grade, high grade, the preferred approach is to actually take a little bit more margin in order to encompass the microscopic extent of the tumor, because glioma is an infiltrating disease, so even has to actually need the extra margin in order to be provide a better local control as compared to the more stereotactic sort of radiation therapy. So unfortunately this patient has this radiation and necrosis, but we don't know about whether truly the beginning of the disease itself, whether it's truly a glioma patient or it is a glioma thing that to be started with, or it is something else. So that's why the importance of biopsy before embarking on any treatment, and also help us, particularly from the radiation oncology point of view, as I mentioned earlier, from our contouring point of view. Thank you.
Thank you, Dr. Asim. So can I ask Dr. Riaz's opinion also? Sir, like Dr. Mazhar also mentioned, like he would ask the neurosurgeon to get us the tissue for the diagnosis before jumping on to any further treatment. What are your thoughts? If you have a treatment, yes, sir.
Thank you, Hassan. This is a very unusual case for because the low-grade gliomas or such type of pictures comes very often we see in our practice. And most of the time, if the patient is having the seizures, we let the patient to keep in observation, because no need for operating the tumor until unless there is a problem, intractable seizures, and maybe a large area of the tumor which need to be resected. But this is very unusual that the patient was underpassed the radiation without the biopsy, and I'm totally agreed with the one of the lady who was talking that lesion is more anterior to the frontal region, but the recurrence of or the things which are seen on the repeat MRI is little bit more to the premotor cortex. So it is a very judgmental how we can think about that this is the same site which is enhancing after the radiation. And we saw these type of the radiation necrosis very, very rare in our practical life. I've seen one of the case who was operated in the AQ by Dr. Juma, and he was a 60 years old male, and he was having the intractable seizures. And the repeat MRI, and it was the glioma, but repeat MRI was continuously showing an area of the radiation necrosis because he was irradiated. And so there was no need for doing the surgery or the redo surgery in that cases. But this is very unusual that the patient has presented with the such type of the lesion which is having the large perilegional edema. On the basis of that, a surgeon who took the decision for a surgery was only on the basis of that the patient was having the severe edema, and the lesion which is seen that looks as a tumor, but unfortunately it turned out to be a radiation necrosis.
Yep.
So what the lesson we are taking from this case, particularly from the radiologist, from the radiation oncologist, and from the oncologist? Do we touch the low grade lesions, and the people are sending the patient for the radiation without any biopsy? This is again very unusual, not to send these type of the patient. If the patient was having only the seizures, why the patient was sent for the radiation gamma knife? without any knowing about the biopsy. And it is again very unusual that the patient who was irradiated, that turned out after within a 1 year, he has the recurrence of he has the lesion. I will rather say that this is the lesion. In the first MRI, there was no any lesion. There was a diffuse type of the hypointense things which were not contrast enhancing in the right frontal region, and that was supposed to be a low grade type of the tumor.
Right. So, sir, I can tell you our practice at our institute, we always go for the biopsy first. Actually, whenever we suspect as low-grade glioma, we go for the maximal safe resection. If it's a non-eloquent area, for example, right frontal, we'll try to get for the lobectomy or as much as we can get. If it's an eloquent area, we think about awake craniotomy or taking just the biopsy if we think the post-op results, or during the surgery, if it's an awake resection, we see any deficits, we stop there and then, so the term that we use here is the maximal safe resection, and that's our practice. And then we present with the tumor board with the histopathology, and then the medical oncologists and radiation oncologists give their opinion how they want to take it further.
Actually,
yes.
Sorry, Ahsan, I was interrupting. You can complete.
No, sir, that's it, sir. Please go ahead.
I was just saying that normally, like if a lesion, a very initial lesion which was seen on the MRI, this patient should have been referred to a neurosurgeon at that time rather than gamma knife, because
right. Yes.
In gliomas and in brain tumors, we have no data of SRS or gamma knife as such. And we don't know what it was and how much dose was given with gamma knife, because it's a very high dose. It might have been a grade 1 glioma. I mean, just simple resection of that tumor and follow-up sometimes is recommended if it's completely removed. So now this patient, unfortunately, had gamma knife without any biopsy, and a very high dose of radiation is delivered, which caused necrosis, and necrosis of the brain does give all the symptoms of like a brain tumor.
Sure. Okay. If no further comments or any questions, and the audience can also ask the questions from our panelists. We have neurosurgeon, oncologist, radiologist. You are most welcome to send in the comments if you want to discuss or ask anything.
I have one question from the radiologist. At the first image, MRI, would it be better that we should go for the SPECT, and if you are not confirmed about the diagnosis, before sending the patient for the radiation, it was necessary to send the patient for the PET scan or SPECT to rule out the further differentials?
So one thing I want to clear, like I think none of us here in this panel sent this patient for radiation before surgery. It was, but after that it came to us. So, but yes, the SPECT question we can take from the radiologist to confirm the diagnosis. Dr. Shumaila, what are your thoughts?
Actually, spectroscopy, the way it is highlighted in literature, it does not help that much in on actual grounds. If I would have reported this MR at the first place, I would have thought about an encephalitis and things like that, and then I would have, send the patient to come after follow-up. I would have advised an EEG. The thing is that most of the times, since I'm working in CyberKnife and I have first-hand experience of past 10 years, most of the times the patients, they come on their own. They are at the first place advised by the clinician to get a surgery, but mostly they are not willing for surgery themselves. And there are so many, people on their right and left, they share their experiences. So the patients, they go for gamma knife or SRS, whatever facility we at JPMC, we never take any patient without a biopsy, because without a biopsy, it is very difficult to decide radiation dose. We don't know the histopathology, and we cannot radiate everything with the same. Like we cannot kill a small mosquito with a huge, firearms. So it's our radiation oncologists, they have a very set criteria. Without biopsy, they never proceed. But there are many people who guide the patients on their own. Patients mostly go on their own for radiation. They are not advised by the clinicians mostly, what my experience is. Because when they come to us and we ask them for a biopsy and a neurosurgical opinion, or whatever they do, the patients mostly go to the next step where they can pay and get this treatment. So um, those are the places from where they get into more trouble instead of getting the benefit. Regarding spectroscopy, coming back to the question, I don't think so that spectroscopy would help much in a low-grade glioma, because basically it is based on the uh, on the number of cells which are proliferating in the tumor tissue. So if this is a low-grade glioma, we will not get those peaks which we normally get in high-grade gliomas. Regarding PET is not very helpful in brain tumors, especially FTG PET, which we have in most of the centers in Pakistan. So it does not help much in categorizing brain tumors. So I think the approach which you shared, Dr. Ehsan, that you go for maximum safe resection, I think that is the best approach at the first place. And the radiologist can just give differentials, because obviously we cannot reach up to the cellular level. And the oncologist, as Dr. Adnan shared, that they need a tissue diagnosis. So I'm sure without a tissue diagnosis, the radiologist, they can give differentials, 2 to 3 differentials or follow-ups, or with the help of additional things, we can try to help the patient and clinician as much as possible. But in few cases, we have our limitations as well. Shayan, would you like to add something?
Yes, I agree with you, Dr. Shumaila, because at times the lesions are at such locations in which the MRS also gives artifactual results. So it is not that helpful. So we radiologists mostly like to follow up such cases in which there is a suspicion of a low-grade tumor.
Thank you. So,
Dr. Ehsan, before
yes.
you proceed to case 2, I have a question from Dr. Asim, if you
Sure.
let me.
Please, please.
So, Dr. Asim, is it the dose of radiation or the area of radiation that dictates the extent of this radiation necrosis? Is it because of the dose, or the bigger the area, the bigger the radiation necrosis?
Dr. Asim is with us.
Yeah, sorry. Fatma, can you please repeat your question? Thank you.
Sir, is it the dose of the radiation or the area covered in radiation that further dictates the extent of progression?
So as far as radiation necrosis is concerned, it's all depend upon the dose. The first thing, the dose, and the other thing is about the area that is being covered actually. So when we are talking about the stereotactic radiation therapy, because the dose is so high and you're given in a very few fractions, that's why the tolerance of the normal brain tissue has changed particularly. So that's why so for in short, it depends upon both the dose and as well as the area that is being actually irradiated.
Thank you.